So we'll today discuss about the management of diabetes in COVID. We all know diabetes is a very common occurrence in patients with COVID, and the people who have diabetes and they have more serious illness. So we'll discuss something which are very practical things. So anybody has any doubt, I will suggest they can raise their hand and they can speak in between, ask their doubts. So that will be a more interactive session, and that will be very practical also. And all these slides, they are based upon the practical experience, not only from our center, but also different centers across the world. So it will be very useful to all of you who are involved in management of COVID patients. So diabetes is very common in patients with COVID-19, and the relationship and coronavirus COVID or the diabetes has a three-way link. First of all, the diabetes increases the severity of COVID-19. Second, it is well proven nowadays that this virus can independently cause diabetes because it affects the pancreatic beta cells, thus leading to defect in insulin secretion. And third, nowadays steroids has been commonly used in very severe patients of COVID-19. Severe patients mean basically who develop hypoxia. So steroids per se can cause blood sugar who have already diagnosed with diabetes. So like we discussed, diabetes increases the risk of COVID-19. So there are certain risk factors associated with diabetes which leads to a poorer outcome. So some of the risk factors are modifiable, some of are not modifiable. So those are modifiable, at least we can target them so that a poor outcome can be minimized. And the final thing I will say, it is very difficult to manage the diabetes. It is not impossible. So it is only difficult if you do not know the principles of management of diabetes in COVID setting. So I will highlight all these things in the coming slides. So next 2-3 slides will show why diabetes is important, how common it is among the COVID. If you see different studies from different parts of the world, we'll see that the prevalence of diabetes varies as low as 8% to as high as almost 1/4 of the COVID population. So let me tell you, these are the all COVID patients, either seen in the OPD or from the hospital, mild, moderate, severe, all category. So this prevalence further rises if you take only severe COVID-19. Severe COVID means those develop hypoxia or have multi-organ dysfunction. So those with a severe patient, the prevalence ranges from 17% to almost 1/3 of the whole cohort have diabetes. So that shows the significance, how important is the diabetes in patients with COVID. Similarly, if we consider the hard outcomes such as mortality, if you see the overall population, the mortality it is like 2.3% to 6.2%. But if we see the mortality among patients who have diabetes, it is almost 3 times or 4 times. So it is very important to manage the diabetes very nicely and to be more careful with the people who have diabetes because it is associated with higher mortality, higher severity, and a prolonged hospital stay. So what are the factors which actually keep these patients for severe outcome? If we understand the factors, then maybe we can target these factors. So these factors may be a modifiable factors or non-modifiable factors. So the non-modifiable factors are like those are higher age, or those are clearly obese or male gender. They are a high risk for a poorer outcome, including death. Similarly, use of insulin is also associated with a poorer outcome. So this has been shown in one study. Let me tell you, use of insulin, why it is associated. usually the type 2 diabetes, they require insulin after several years of diabetes, like 5 years, 10 years, 15 years. So insulin use indicates that they have several complications, like they might have microvascular complications like neuropathy, nephropathy, or macrovascular complication like coronary artery disease, stroke. So higher the duration of use, higher the chance of insulin use, and higher the complication. So that is the reason they have poorer outcome. Similarly, many of the diabetic patients may have hypertension, cardiovascular disease, renal disease, or COPD. They are also associated with a poorer outcome like in any other studies. There are 4 studies. Out of those 4 studies, 2 studies shows that if the patients have a higher HbA1c, they have poorer outcome, while other 2 studies do not show. So A1C shows what is the long-term blood sugar control in the previous 3 months. So if you look carefully, all of these are non-modifiable risk factors. If somebody has it, has it. Only 2 modifiable factors are hypertension and A1C. So how we can target them? So it is only targeted for those patients who do not have COVID. Like when they come up in the clinic, I don't know how many of you see COVID diabetic patients and hypertension patients. If any of you are managing them, you should target to achieve a good BP control and good blood sugar control for all the patients who have not catched a COVID-19. So in those patients, achieving a optimal BP and optimal blood sugar control will help them not to get a very severe infection. So if somebody has a good A1C, good BP control, good blood sugar control, if at all they catch the infection, the chances of getting a serious infection, serious disease is low. Another factor I would like to highlight, that's why I have kept it towards the end. It is completely modifiable. It is in control of our hands. This is the blood sugar control during the hospital stay. So those who are involved in management of COVID patients might have seen when these patients come to hospital, they usually have a very high blood sugar. If these blood sugars are not controlled, there is a very good chance that those patients will have a severe disease. It is well proven in a very large study. This study involved almost 7,000 patients, and they try to study what are the survival in 2 groups. The first group consisted of patients who had well-controlled blood glucose throughout the hospital stay, that is 70 to 180 milligram per dl. And the second group controlled a poorly controlled blood glucose at any time during the hospital stay, even for a 1 day also. And they found that those had a So this orange color graph is the poorly controlled blood sugar anytime during the hospital stay, and this blue color is the well controlled, and this in y-axis is the survival chance. So we can see that those had the poorly controlled blood sugar had lower chance of survival, and it is statistically really significant. The p-value is really significant, 0.008. So these studies also showed those had a poorly controlled blood sugar anytime during the hospital stay had higher risk of mortality, septic shock, ARDS, acute kidney injury, and acute heart injury. So the gist of this study is we should take optimal care so that blood sugar remain very good in very good control throughout the hospital stay. So with this background, I'm going to discuss the management of diabetes during the hospital stay. So I will give you a few examples so that it will become very clear to you. So I like to interact with the participants. So may I request all the participants may unmute the mic so that we can discuss, because they are very practical So this is a quite common scenario, those having mild to moderate infection. So this was a 70-year-old male who is weighing around 60 kg, already a known case of diabetes, who has a very good blood sugar control on oral agents. And we did a hemoglobin A1C when he got admitted, which was 6.7%. That means it is very good control. Any A1C less than 7% considered to be a good control. So he had normal vitals. He was maintaining saturation. On day of admission, his RBS was normal. There was no vomiting, no renal dysfunction, no liver dysfunction, no cardiac dysfunction. So what we did, the RBS of 204, that is optimal, okay. So what we did, this was during the initial days of COVID. So he was given azithromycin, oseltamivir, and hydroxychloroquine as the part of his protocol. And blood sugars are okay. He had no liver or renal failure, no vomiting. His appetite was okay. So he continued the oral agent. And we used to monitor the blood sugar in the hospital. So on the day 3, his blood sugar rose up to 240. And the glucometer monitoring showed all the blood sugars are elevated. So this is a situation what the people did who are managing there, they increased the glimepiride from 1 milligram to 2 milligram. But the thing is that is not ideal, because if you increase the oral agent, it will take some time for its control, at least a week or 2 weeks. By the time patient might have discharged or might have worsened. And it is really important to control the blood sugars immediately. So none of the oral agents can control the blood sugars immediately. Even within 2 days, 3 days, it is not possible. That's why when we have to achieve the blood sugar control immediately, we have to go to the insulin. So this is a subcutaneous, also called basal bolus regimen. Why basal bolus? Basal means it is a long-acting or intermediate-acting insulin, like NPH, which is an intermediate-acting insulin. Usually works for 12 to 16 hours. Since we have to give 2 times a day, so that 24 hours the blood insulin levels are maintained in the fasting condition. What is the bolus insulin? The bolus insulin is the short-acting insulin, such as regular insulin, which is given before the major meals, breakfast, lunch, and dinner, which will control the rise of the meal-related blood sugar. So this is typically called a basal bolus regimen. This is the standard regimen for all the patients who are eating in the hospital. There is no role of any mixed insulin. That's what I am trying to say. The mixed insulin has these two insulin, NPH and regular, in a fixed combination. Unfortunately, that fixed combination does not suit most of the patients. So, for a rapid titration, rapid control, this insulin regimen is preferred all over the world. So, patient improved blood sugar control and he did not have any renal liver dysfunction. Hence, we discharged the patient on OHA because he had a very good control on those insulin. So the learning points here, the poor glycemia was because of the infection per se. This infection usually leads to insulin resistance because of the cytokines. Second thing, if the blood sugars are not controlled on oral agents, the dose escalation of oral agents is not advised because there is a time lag. Third thing, which is important for many of you, if the patient has COVID and well controlled on oral agents, the oral agents can be continued. If there is no renal liver dysfunction, patient is eating nicely. This is a very common scenario nowadays where the pre-existing type 2 diabetes is worsened by steroids. Yeah, so now I think the transmission has restarted. So this is a second case which is very classic nowadays, where a pre-existing type 2 diabetes worsened by the steroids. So this was a classical example which admitted in our COVID hospital. He did not give us any history of diabetes. He presented with fever, cough, dyspnea, and he had tachypnea. He has low oxygen saturation at room air at admission. So he was put on oxygen, and at admission, when we checked his blood sugar, this was 466. So we started him on insulin. So this rise a high blood sugar. This may be because of this infection, or it might be there is a pre-existing diabetes which got worsened by this infection. So how to know that? Usually this can be known by doing a hemoglobin A1C. So we send the hemoglobin A1C, started him on insulin, again basal bolus insulin. So this was the regimen which was started. So the A1C came to be high, 10.9%. That means the patient had pre-existing diabetes. When in the hospital, first time we see a blood sugar of 466 or high blood sugar and the A1C more than 6.5%, that means the patient has pre-existing diabetes. If the A1C is less than 6.5%, that means it is a new onset diabetes. So this patient falls to a severe disease, hence he was started on dexamethasone, remdesivir, low molecular heparin, and with initiation of steroid, his blood sugars actually remain very high. So you can see this is the amount of insulin this patient required for his blood sugar control. So which is a very common thing in many of these patients. Because the COVID causes insulin resistance, it also leads to insulin secretory defect, it also causes worsened by the steroids. So these patients are not uncommon to require such high doses of steroid. If you calculate, there is around 240 to 50 units of insulin. So even with this much of insulin, even the blood sugar remain high. So that is an indication for initiation of insulin infusion. So when the patient improved, we again switched back to basal bolus, and when the patient clinically improved, the insulin dose also reduced very drastically, and he was finally discharged on insulin 1 unit per kg, around 60 units per day. So when the steroid dose is tapered, we have to be very careful to monitor the blood sugar and reduce the insulin dose carefully. This is a third patient, just like the previous patient, but here we can see the high blood sugar, but he has a A1C of 6.4%. That means the blood sugar elevated because of the infection and here because of the steroid. So whenever we discharge, we should be very careful in prescribing any OHA, and we should ask a physician, a medicine specialist or an endocrinologist if available, what to do for this kind of patient. So I will skip these slides. Now we come to the management proper. So all the patients, so whom should we screen for blood sugar? Should all patients should be screened for the blood sugar? The answer is yes. All the patients who are getting admitted for COVID, whether they have diabetes or they do not have diabetes, they should be monitored for blood sugar. Even if they do not have diabetes, we check the blood sugar. If it is more than 180, using a glucometer, we should check the blood sugar testing 4 times a day, at least for 2 to 3 days, and we send a hemoglobin A1C. If the A1C more than 6.5%, the patient falls with a diabetes, and if it is less than 6.5% and the bloods are okay, we should discontinue the monitoring after 2 days. If the blood sugar, all the blood sugar less than 180, no need to monitor. So when we are starting the steroids, the blood sugar should also be checked for 2 to 3 days. If they are less than 180, all the blood sugar, monitor further, or at least once a day we can check whether the blood sugar are rising or not. So if the blood sugar more than 180 at any time, we should also continue 4 times a day with appropriate insulin therapy. So those having diabetes and patients are critically ill, the patients should be put on insulin infusion and the blood sugar monitoring should be done every 1 hourly. And those are non-critically ill and eating, the blood sugar testing should be done 4 times a day. What does this mean by 4 times? This 4 times usually mean it is before all the meals, breakfast, lunch and dinner, and 2 hours after dinner. The target for the pre-meal blood sugar should be less than 140 and the post-meal blood sugar should be less than 180. And those are critically ill and on insulin infusion, the target should be between 140 to 180. So another thing I would just like to mention regarding this cluster care. So many times the healthcare workers have anxiety visiting the patients frequently. So to avoid frequent patient contact, we can use this cluster care. What does that mean? For example, during the lunch time, the patient needs blood sugar monitoring, insulin administration, So these two things can be done simultaneously, and the same visit, the nursing staff can give the patient his or her oral or injectable medications, and if any clinical assessment like pulse, BP, or anything can be done in the same visit. So that will minimize the patient frequency. So what is the treatment regime? Previously, I have mentioned that a very small set of patients can be managed on OHA, basically whose blood sugar are controlled and they are eating adequately and they do not have any organ dysfunction such as liver failure, kidney failure, or heart failure. Apart from all those patients will require insulin. So if they are critically ill, they will require insulin infusion. If they are mild, moderately, severely ill and eating, they will require subcutaneous insulin. So if the previous insulin regimen, the blood sugars are controlled, we should continue that insulin regimen, even if it is a 30-70 or Mr. type of insulin. So if it is not controlled with the previous regimen, we have to initiate basal bolus regimen, which we discussed previously. Coming to the oral agents, a few words of caution because a major group of patients will be on oral agents when admitted to the COVID hospital. So if any patient here, such as glimepiride, glibenclamide, so we should be very careful for hypoglycemia in those who are elderly, who has renal failure, or who are receiving insulin, because in this patient the risk of hypoglycemia is higher. So if possible, in this group of patients, we should stop the sulfonylurea. Metformin can be continued unless patient has renal failure, liver failure, or the patient is in sepsis or shock or have hypoxemia, because in this group of patients the chance of metabolic acidosis increases. Similarly, the DPP-4 inhibitors like sitagliptin, linagliptin can be continued unless the patient is critically ill. However, in our country, we do not use the saxagliptin, alogliptin, but very few patients we can find on saxagliptin. This should be avoided. I'm not going to put a lot of discussion on this because these are very minimal used in our country. But any patient on SGL2 inhibitor, for example, dapagliflozin, or GLP-1 receptor agonist such as injection liraglutide, or on pioglitazone, that should be stopped even if patient mild to moderate ill. Discussed two common insulin regimen. One is insulin infusion. This is required for all the critically ill patients. And like in the case 2, where the steroid-induced hyperglycemia not controlled with very high dose of insulin, or the patient have classic indication like diabetic ketoacidosis or hyperosmolarcoma, there the insulin infusion has to be given. Where in rest of the situation, we have to give basal bolus insulin. These are the special situations. I really doubt many of you involved in this, so I am skipping this section. Another thing I will mention is the incidence of diabetic ketoacidosis is very high in these COVID patients. We can only detect if we do a urine ketone using some sticks which are available in the pharmacy. So any patient who has a blood sugar more than 250, we should do a urine ketone. If the ketones are positive, we should manage as per the protocol of the DKA. So there are a couple of studies. You can see the prevalence is really high. Usually this is not seen in the classic patients of type 1 diabetes also. So the prevalence is really high in patients with COVID. Even we can see the patients got COVID but did not have diabetes. They have also ketosis. So one should really check if the blood sugar more than 250. And the other thing which is really significant, those who have decay, they have a very high risk of mortality. So here is a one part where the physician, or if there is someone from intensive care specialty, or if somebody has a virtual or telephonic contact with a endocrinologist, they should be consulted if you find a patient of decay. So to summary, all admitted patients of COVID should have a routine blood sugar monitoring, even if they do not have diabetes. We should monitor these patients for new onset hyperglycemia or diabetes. So at least once a day monitoring should be done, even if they do not have diabetes. And management is difficult. because steroids can really worsen the insulin resistance, and this may lead to high dose of insulin requirement. And diabetic ketosis and decay incidence is really high. So the blood sugar target should be pre-meal less than 140, post-meal less than 180 in the patients who are not severe and eating nicely. Subcutaneous basal bolus insulin is the regimen of choice where the blood sugars are not controlled. Previous oral regimen can be continued in a few where blood sugars are controlled and they do not have any organ dysfunction. And those are severe or critically ill should be put on insulin infusion, and the blood sugar goals should be between 140 to 180. And these patients should be monitored for blood sugars, ketone, electrolytes regularly, at least 2 times a day.